So this was a project about minimally invasive total arthroplasty. For those who may not be familiar with the procedure, it's pretty much a hip surgical procedure which usually uses a smaller incision compared to the traditional one that we're used to, the 10 to 10 and above centimeters. So this one is smaller incisions, 10 or less. So patients pretty much like this because of cosmetic reasons. So according to the unit manager for the orthopedic department, this procedure is very popular in that department. So they needed a curriculum to guide the staff. Especially now that they have newer staff, the previous ones are pretty much retiring, so they need a curriculum pretty much to have like a standard of care so that people will know what to follow in terms of different procedures when they're dealing with this, because minimally invasive arthroplasty procedure has a little few diverse things that you can do pretty much compared to the traditional one. So that's what the whole project was all about. So my task was to come up with a curriculum development for this procedure. And before doing this, I wanted just to find out, have a baseline, what do staff know, so that I don't have to duplicate what they already know, plus how much, what are the areas that are a little pretty much current or that needs a little review based on what the evidence shows out there. So we came up with a survey, which was a 10-point survey generated from a literature review. So we gave this 10-point questionnaire to staff members. We issued 30 of them, and we were able to get 40. We issued 30%. 30 of them, we were able to get 14 of them back. And based on those, based on the results after reviewing what the results, what they came up with in terms of what they knew, we found that they were pretty much very clear. They were actually very good at identifying different procedures and what needed to be done in terms of complications, pain management, and etc. But there were a few other areas that were a little different for this procedure compared to the traditional hip procedure. So for example, in this case, we had one of them was predisposing factors for incision and dehiscence. So basically for this one here, they had, the literature shows that there are a number of things like history of hypertension, history of anticoagulants and antiplatelets use, and being overweight and having renal insufficiency and etc. Those were also part of the things that would contribute to risk factors for this patient population. So staff were able to identify a couple of them, but there were 3 other areas that they weren't really aware, so we included that in our curriculum. Then also, for dislocation precautions, for this procedure in particular, really literature evidence shows that there's no real precaution required compared to the traditional one. Traditional ones really, they prefer, for example, having like abductor pillow, preventing patients from bending or beyond so many degrees, or even driving restrictions and so on. The literature really, a couple of them were recommending that really there should not be restrictions because patients need to be getting up more and get better results when they don't. So we included that in our curriculum, but we'll talk about what the measures are going to be. Then factors and implications associated with controlled pain. So that also, staff did very well with that, but there were just a couple like decreased wound perfusion. That would be a sign. Uncontrolled pain would lead to decreased wound perfusion. And pain also being a possible cause of depression and all that kind of stuff, for example, delirium and etc. So those are the areas we also noticed that most of the staff were not very clear, so we included that. So there were other places that staff did very well, but we also wanted to reinforce those for the newer staff who will be looking at the curriculum in future, so we included that in our curriculum development. So these were the contents of the items that we have in our curriculum. And I already forwarded that to Lee, so she can share with you. So for a recommendation for this, we're not recommending that anything be changed right away before discussing with the surgical team so they're all on the same page. So that I think the best way to go is about to share this with them, have their feedback, whether they want to implement the new evidence or they want to continue the older way, so there's no contradiction with what staff are expected to do. So for the future, in conclusion, really the curriculum was necessary. And right now I just submitted it to Lee, and hopefully if there are any questions or if there are any areas that are not very clear, hopefully I'll be able to take care of this today and tomorrow, then share it with the rest of the department stakeholders. And that was it.
So perhaps when you say that you've developed a curriculum, perhaps you could describe that, because some people, when they say a curriculum, they just mean kind of the educational objectives and an outline, and sometimes people then mean a particular modality and a presentation like a learning management system. So maybe if you could just describe that a little bit more, I think that'd be helpful for the group.
Okay, so this curriculum again focused on areas that had a little, we focused on mostly on areas that identify where we noticed the gap, but also reinforced other areas, but mostly in an outline format, because the unit department manager had requested an outline format so staff don't have to be reading lots of bulky paragraphs. So we made it more like bullet points, so it's for quick reference.
Mm-hmm. Questions from you guys about the approach or the survey or identified priorities?
So with your education plan for the staff, I heard you had a curriculum, but did you discuss what type of educational tools? You said had outline format. Are you using simulation? Are you using PowerPoints? Are you just using didactic, or is just a manual type outline?
Okay, so it's going to be PowerPoint. Mm-hmm. Yeah, PowerPoint format.
Mm-hmm. Was there a kind of a philosophical or a theory undergirding your assessment of what our gap in knowledge was?
I beg your pardon.
Was there a theory or a framework that you used in doing the assessment?
That's right. So I used the knowledge to action framework.
So maybe you could, because not everybody in here is educators, they might not know that.
Okay, so the knowledge knowledge to action framework has pretty much about 8-point steps to follow. So we took the first two, which was pretty much knowledge inquiry, which was literature review. Then the second one was identifying the problem, which was baseline, passing out the baseline assessment to the staff just to see where they are. Then also adapting knowledge to local context and assessing barriers. So that was pretty much interviewing the department stakeholders. So I did get an opportunity to interview the department, orthopedic department manager, the clinical nurse specialist director, the pain specialist, and the care map coordinator. This was Naomi. Yeah, just to get a feel of whether they were really up to this, where they were, so I don't have to duplicate what they're already doing. Yeah, so that was pretty much. So the rest of the steps, for example, implementation, monitoring, knowledge use, evaluating the outcomes, that was beyond this project, so that's going to be the duty of the clinical specialist. And
Great. Any other questions from the group? Anything else you think that there are really key points that you want us to remember, particularly as we look toward implementation?
Okay, so the key point is pretty much, we did the baseline assessment and only, I think we had 50% participation, but it's better, I think it's good to have a feel of what other people have in mind, so we don't have to, so have a feeling of what the rest of the department staff members, where they are, so when this is being implemented, that would be a good place for whether it's implemented to emphasize areas that they still gap. So I think it would be a bad idea to re-administer the pre-test again for the entire population, then implement, then give a post-test, see where they are.
Great. Anything else, Michelle, from your area?
No.
Okay. Thank you very much.
Thank you.
Thank you.
Important topic.
Alright, so my project was to help design a mentorship program for novice nurses. So I'll pass this around. This includes my executive summary, literature appraisal, outline for the program, and the research. So why is this a problem? Why do we need a mentorship program for new graduate nurses? And the statistics show that about 50% of new nurses leave the field within the first year. And it's really costly. It costs hospitals estimated $40,000 to $60,000 per nurse. And it can even be upwards of $100,000 in specialty areas. And there's also an additional 80% for loss of productivity of the upfront turnover costs. So it's very costly. It's a big issue. So to address this, first it's important to know the difference between residencies versus mentorship programs. A lot of hospitals are utilizing residency programs to address this, which is very helpful, but it falls short in some areas. A residency program is more short-term. It lasts usually about 2 to 3 months just to get those core skills out and kind of teach the policies and rules. But then when it ends, a lot of times the new nurse feels kind of stranded, that they don't have that ally anymore, that they've become their peer. And usually the learning's one way. It's going from like the teacher or the preceptor to the new nurse. With a mentorship, it's different. It's sort of long-term. It's usually after a residency program. It usually lasts about a year. And it's more about forming goals, sort of like a big brother, big sister, sort of navigating those rocky waters of, you know, hey, I work the night shift, and here's some tips, or I remember my first med air. And it's more symbiotic where the mentor can also gain sort of by altruistic sharing. So, and a lot of times the residency programs are also called internship, preceptorships. So for this program, I used the Ottawa model to sort of assess barriers, facilitators, and culture. So I talked to Leigh, Caitlin, and Melissa, kind of get the general idea. And then I also attended the new nurse residency graduation day, and I interviewed all the new residents about their perceptions of what a mentorship program was, what they would like to see in it, their preferences. And then I also did a literature appraisal of all the evidence out there, and I also surveyed all the local hospitals I could, and I tried to survey any hospitals outside of Washington that would talk to me, which was challenging. I'll talk more about that later. And then basically the idea was to kind of collate, bring together the best evidence and recommendations from the surveys, from the literature appraisal, and sort of what I'd seen online. Just kind of form a good mentorship outline that can be modified and implemented to best meet Northwest Hospital's needs. So the big barriers were, among the literature, there's not really a very well agreed upon definition of what a mentorship is as we define it in this project. A lot of times they're using preceptorship, internship, residency interchangeably with mentorship, and even the articles be labeled mentorship when it really, by this definition, it's more like a residency or preceptorship. So that was challenging. There were a limited amount of studies. A lot of them were kind of pilot studies. They're still publishing more in-depth results. So that was challenging. And then also, for surveying, most hospitals wouldn't advertise very well. They would label it wrong, or it was very difficult to get a hold of people, get people to talk to you, return your calls. So those were the barriers. But I was able to, I found 6 good, decent studies about the programs, and they're basically divided up into a few different areas. All the programs, they have a kind of a standard length ranging from 12 to 18 months. They have a matching process, sort of where they have a minimal requirement. The average seems to be about 1 to 2 years for their mentors, and how they select them. So some of them are personality profiles. Sometimes it's random selection. Sometimes it's preferences. Some pay, some didn't pay, some didn't say. They all had a standard training process for both the mentor and mentee, so they know their roles, their expectations, of what's expected of them. And there's always an oversight team sort of to manage conflicts and escalate things as they came up. And then it varied with the meetings. Some programs were very structured with materials that they wanted the mentees and mentors to go through every meeting, and some were just kind of loose, just meet and talk about whatever. But they were all usually meeting once a month. And then the evaluation, sometimes they had surveys up front, like 3 months, 6 months, 12 months, and at the end. And then some were just at the end. But from this, basically, the recommendations that came about were that there needs to be a real structured oversight team to manage the issues. And the more you can get the agency to buy in, the more successful it is. Because if they don't buy in, then usually the program ends up crumbling. And also, they were saying it's very important to incentivize the mentors to get them to follow the program properly and meet regularly. And also to have standard measurements. Big problems among the literature were where the program wasn't very structured, or the team wasn't necessarily checking in enough. So there'd be some of the survey results, but not all of them. So the data was real inconsistent and hard to, get a true idea of what was going on. So those were some of the core things that were recommended. And then also it is real important to have strong education for the mentors and mentees so they knew their roles. A lot of times there were complaints about them not knowing exactly what was expected of them, what exactly does a mentor do, what does a mentee do, etc. And then over here for the hospitals I met with, I kind of broke it down into the same categories. It seems like most programs in the area, I was able to get a hold of Seattle Children's, St. Peter's, Harborview, UW Medical Center, and the only one I could get outside of Washington that was advertising was the University Medical Center in Texas. So I wish it would have been a little broader, but that was sort of the best we could do. Their programs were average about 18 months, 3 months residency, 12 months mentorship. They had various ways of matching, but usually it was about 1 to 2 years of experience. And I had somebody from Harborview tell me that when they're looking for preceptors, they're looking for people with more experience to teach the skills really well. And they say for a mentor, in their opinion, they felt it was better to get someone who had a real outgoing personality, someone who was real bubbly, to sort of help the person along. And also that kind of widened the pool because it was challenging for them at their location to get people with like 3 or 5 years of experience. And then all the places I talked to were paying their mentors and incentivizing them, and they felt like that was important. But also one of the biggest challenges was to get that approved by management, upper management, and also sort of keep the momentum, keep the buy-in. They all had some sort of standardized training. They were all meeting once a month. Some were more structured than others, and then they all had various survey ways to sort of evaluate it. But it seemed like the most successful one, this one in Texas, this UMC, theirs was very structured. They had set materials for them to complete each time. They had strong buy-in. They were paying them, and they had real defined education classes. And they would actually give mentorship programs not just to nurses, but also other staff members who worked in other departments. And universally, from the evidence and hospitals, it showed that the mentorship program does work if it's used effectively, that it definitely reduces anxiety, improves confidence, it reduces turnover. If done properly, it's very effective, but there's not necessarily a fully agreed upon way to do it, or the evidence isn't strong enough to point it one way or another. So what I did is, for my outline, I created a program based off of the Academy of Medical Surgical Nurses mentorship program, which is based off of this top Grindle and Hagerstrom article. And basically it's nice because it's free, it's open to the public, it can be modified, and it has very easy to use survey evaluation tools that can be used, so you can really track if it's working or not. And I know after this project, Northwest was hoping to pilot it, and this project didn't allow enough time to do that. So it would be really easy to track with, and it's free, it's modifiable. So the way this program works is they would have the initial 3-month residency, and then immediately afterwards this mentorship program would start. And bringing in components of the way they did it at Harborview is they sent out letters based off of upper management's idea of who would be a good mentor, sort of those people with outgoing personalities. So they would send letters to sort of invite them to be a mentor, and then there would be a contract sort of outlining what they were getting themselves into. And then based off that, the matching process could be done by either speed dating, personality profiles, requests, random selection, and we'd want to pay close attention to same shift, same weekend. And I was recommending 1 to 2 years experience minimum, because that's what I was seeing in all the local hospitals and among the literature. And the training, this was based off of Seattle Children's. They found it very effective to have 4-hour mentor classes. So the way this would work is the residents would get that 4-hour mentorship training during the residency program. So that would be out of the way, and then there would be a separate 4-hour training for the actual mentors. And then the oversight team, it could be modified, but it's very important for that to exist. And the structure also of Seattle Children's, they were using they have an oversight team, which could consist of the education department, and then every unit they try to have sort of a mentor coordinators, so they could all kind of relay information, keep the mentor pool large, and then they would also kind of track to make sure people were meeting regularly. And then if they weren't meeting regularly, they would kind of escalate it. And then I would use the standard evaluation measures outlined in the AMSN, or Academy of Medical Surgical, to assess. And they do survey questions at the beginning, 3 months, 6 months, and 12 months. And what's nice is it comes with three real easy to use guides. There's a mentor guide, a mentee guide, and a site coordinator guide. Very easy to use, very structured, and very modifiable. And then I was also recommending, if possible, to pay the mentors to meet, once or twice a month. So I mean, I know that's the hardest challenge, is to get that approved to pay for. But if you kind of think about the numbers, even if you take sort of a novice nurse 1 to 2 years, maybe estimate $30 an hour times, even if you had to meet 2 hours once a month, that'd be $60 a month. So for the 12-month duration of the program, that'd be $720. And if you compare that to $40,000 for the price of replacing one nurse, plus, in the long run, if you could get the agency to buy into that, that's just for the 1 to 2 year nurse. And even if you run someone expert making around $50 an hour, if you go $100 for 2 hours once a month, times 12 months, if you come up with $1,200, even at the highest end, compared to $44,000 at the estimated lowest end, it'd be worth its weight in gold if it was set up right and structured. So my recommendations is to sort of the outline I have outlined here, modify it to meet whatever needs or obstacles you guys have, and go from there. The pilot, and use the Ottawa model to carry it forward.
Questions? Nathan, I have a couple that just occurred to me as you were going through there. It sounds like the hospitals that you were able to interview are all fairly large academic medical center, and we're a community hospital. Well, obviously part of UW Medicine, but it's still a community hospital, a little bit smaller. Were any of the articles in community hospitals, or were the articles tend to be in larger academic centers too?
It was kind of a mix-up. A lot of them didn't fully specify.
Okay.
And some of them were looking at multiple hospitals, like a lot of them were multi-site.
Okay.
So it would be hard to say, to compare a community, since there were so many different sites.
Okay, so you...
But the ones, there's Providence, St. Peter's, so I'm not sure. In my...
Providence, St. Peter's is probably close to our size.
So I thought that was probably around the same. But I actually outlaid in the mentor survey, I kind of wrote how many beds each of them compared, and it seemed like a couple of them were the same size.
Okay,
I don't know if they're a community, but they were similar.
Great. And I know that, in having looked at this before, that their measuring of outcomes is always challenging, because they always use different methodology. But in the intro, I think I heard you say that about 50% of nurses that are new graduates within 2 years are thinking about leaving the profession or leaving that position. Was there any of those kinds of outcome measures with actual reduction in turnover from either the literature or from the other organizations that have implemented?
Well, from locally, I have it outlaid more in my survey, but a lot of people were able to bring their, I think it was Harborview, over 7 years they were above the national average of turnover, and they took it down to 0.
Is that turnover overall turnover, or turnover for the RN residents?
For the RN residents.
Okay.
Yeah.
Okay. And they think a big part of that is their mentorship program.
Yes.
Okay. Other questions you guys have?
I do. What exactly, how much time is the mentor supposed to spend with the new resident, and what kind of things are they supposed to be doing? And do they have to document? Is somebody supposed to document and then turn something in?
Yeah, so it looks like most of the hospitals were doing 1 hour. Seattle Children's was doing 2 hours once a month. And I have included in here is like a tips and trick sheet. They kept it kind of loose, where they had some general topics to bring up, but the AMSN kind of has select things that they can do ahead of time to sort of talk about, so it's sort of semi-structured. And then they found it helpful at Seattle Children's to actually have them send an email to the manager each time they met, and since they were paying, they were getting it pre-scheduled by the scheduling manager, and then they had an escalation template that I included in there, sort of inevitably when people aren't meeting, how to do it kind of in a nice way, like, hey, we noticed this or that, and then kind of the process to go forward if they're not meeting.
So are they just kind of, just from what you read in your articles and stuff, were they just kind of like sitting down and saying, hey, I'm so-and-so, I'm gonna be your mentor, you know, how are things going? Because I can just see a conversation between two people. Yeah, everything's going great.
Okay, you're good,
You
I'm
know,
good.
yeah, I'm good.
Yeah.
Have you had any challenges? No, I'm good, you know, and I can just see, so is there,
Sure.
I mean, did anybody give any examples of things that they
Yes.
talked about?
So this program in Texas had something so structured that the hospital came up with where they actually had to check a box for everything, like we talked about this policy or that policy, and we had a set agenda every day, so it could be that structured. This program, the AMSN, has sheets that can be used for each meeting, so that could be made a requirement or not a requirement. So it's really kind of up to the hospital and how flexible you want to make it. But I do know that St. Peter's, they were in the process of modifying their program because they said they felt like there weren't enough goals, it wasn't structured enough, that it was kind of becoming, like how you said, too loose.
Yeah.
And they were losing their buy-in from management. So it's kind of as structured as you want it to be, but there's some tools in there that are really good that you could go from there or make them more specific or less specific.
And how did the mentors feel about doing this? The people that were actually doing the mentorship, was there anything that was ever stated about,
I didn't
you know,
really-
did they find that it did they feel that it benefited the,
Yeah, that's a good question. I didn't specifically ask sort of the mentor's point of view. The main survey questions I was asking is sort of why did you adopt it, what's working well, what isn't working well, what were the biggest challenges for implementing it, and then what are your outcomes and how have you measured this. But I didn't hear from any of them getting a lot of pushback from the mentors with it, especially if they were paying them. I could see like if they weren't paying them, but
because it seems like if you're gonna sit down and you're gonna have a checklist about like what you're gonna go over as far as like protocols, procedures, that type of thing, it seems like that's just an extension of the preceptor. But maybe I'm confused, so.
it was kind of a combination, so they had that involved, but plus just kind of the free checking in, how you doing, what are goals. It was sort of a more prolonged version of it, but with more personalization on the.
It's been my experience, some people put that structure in there as a kind of an icebreaker and reinforcement, but the real mentorship part of it is the dialogue and how you're developing in your profession and how's it going on your units and you know, how are you developing as a professional. But they put a little bit of that structure in there in order to be able to start the conversation rolling.
From any of the places that you interviewed, were any of them not paying people to be mentors?
All of them were paying, yeah.
Okay.
Harborview, Providence, UW Medical Center, Seattle Children's, and then this one in Texas, UMC.
I know all of the rest of those are unionized in our local area. Do you know what the Texas one is, a unionized hospital? And that one was doing it beyond nursing, right?
Yeah, beyond nursing for
Yeah.
all staff, yeah. So, no, I didn't get
So
that
here for
question.
the Northwest, it's usually, that's one of the big factors.
I'm wondering and maybe you can speak to this or maybe not, depending on the sizes of the hospitals, but one of the barriers that I'm kind of anticipating is having such a small nursing staff to begin with and us onboarding so many new residents.
Right.
Have any of these mentorship programs looked at or utilized a one mentor to maybe two residents or
It's actually
anything
really
like that?
interesting you say that. So Providence, St. Peter's, they were kind of having an issue getting enough mentors as well. And they're actually looking at the concept of group mentorship. And I kind of looked for some articles. They came towards the end of the project, but I was interested kind of learning more about that, and I couldn't find anything really published about it yet. But it's the idea where they meet more in like a group fashion. And I guess somebody out in California did a study about that, and they showed that that can be real effective too. So it seems like any sort of support is better than no support, but that could be an idea, like if it's really a problem, to explore maybe a structured group mentorship.
Yeah, I think that would almost be better, I would think, because you're, again, teaching the team environment, and you're also, or the team concept with collaboration of things, and you could do literature.
For sure.
If somebody was having an issue with conflict on their unit or something, you can say, okay, well, let's all take a look at an article maybe going over conflict when we meet, or something like that.
Were most of these programs based out of a unit, or were they kind of managed by a larger organizational department?
Some were just out of a unit, like this one at UW Medical Center was just out of a unit.
Was that the oncology unit?
Yes.
Oh, they've developed that quite a bit. I worked on that unit.
Yes, that was out. That
They
was
were
out
not
of a
paying
unit.
when I worked there.
I remember the
UMC was system-wide, St. Peter's was system-wide, Harborview Medical Center was just on a unit, and I believe Seattle Children's was just on a unit, so they weren't all hospital-wide.
Okay.
Still kind of small, still kind of experimental, but some of them seemed pretty well, like the UMC one was real established and working well, and the Seattle Children's seemed real established and working well.
Anything else for Nathan?
I'm wondering, does this tie in with hospitals gaining magnet status, do you know?
I don't know, that would be a good question,
So
that'd be a good carrot.
it's not required for the magnet designation, but you can use it as looking at your infrastructure for supporting nursing and nursing practice and socialization and professional development in nursing. So you can tie it in as one of the things you're doing uniquely at your facility, but it's not a requirement of the magnet program. I just want to thank all three presenters, and from my point of view, we're definitely looking to grow our orthopedic service, and we definitely have had a exodus of some of our experienced orthopedic nurses. So being able to get some assistance and support and some information about developing orthopedic curriculum and what the learning gap is was very, very helpful. We obviously, not just us, but the whole, this part of the United States is having a lot of problems with psychiatric inpatient stays and psychiatric certifications on the inpatient med-surg units, and it provides a lot of angst. That's been a growing population for our hospital, and it really is a real stressor. And certainly we are looking at other ways that we can strengthen our RN residency program. We've done a lot with the crossover of the residency program this year. These two ladies are pretty exhausted by
Going around town.
And just so you know, Nathan, since we started this conversation, the organization has committed to to pilot a program called New to Northwest Nursing, where we bring people together that have been hired in the last 6 months and have a structured 1 hour facilitated by a CNS just dialogue as a way to start the dialogue with the people who have already been going through the program as we look at your recommendations and see what we want to do for the future. There has been the question about why are we doing this for our new hires and we're not doing it for our current people, so we're in dialogue with our chaplain to see if we can do a program that they've done at some of our partner hospitals. Actually, I think it's SCCA, called Tea for the Soul, so that there's an opportunity for staff nurses to be able to come in and talk with the chaplain and just recognize that nursing can be a stressful profession, and that we all have to take care of ourselves so that we can take care of our patients. So there is some activity in all three of these areas. It's not fully developed yet, and the information that you've provided us will be very, very helpful moving forward. So I want to thank all three of you for your excellent
So this project started because there was an increase in patients on a local telemetry floor, probably that one over there, with psychiatric and physical health illnesses. And so nurses on the unit were saying they were feeling burnt out, they're frustrated, they didn't really sign up to work with this population, they don't really know what to do. And so, education department, nurse manager asked for a project to help support their staff. And so it started just by looking, you can see this fishbone diagram, hopefully, at the different factors that were going into nurses feeling overwhelmed and not prepared to for these patients. And so, first off, it's a difficult patient population. They are patients not necessarily with like mild anxiety. These are patients a lot of times are involuntarily detained. They're suicidal, they're homicidal, they're actively psychotic, they're manic. Some of them have co-occurring substance abuse issues, and so they're sneaking drugs onto the unit and overdosing. So it's a difficult population that would be difficult even if it was on a psychiatric unit, but it's not. And so that's the other factor that we looked at, was the environment of the unit. And so difficult population, caring for it on a non-psychiatric unit. So on a psych unit, we don't really have scissors around, we don't have dangerous objects. It's a locked unit usually on a psych unit, and so people can't elope. It's much harder to sneak things in, and so they don't have that. Another factor was mental health stigma, and this was identified from clinical nurse specialists and from nurses, that not everybody has the same understanding of mental illness. Some nurses have been assaulted, have fear about mentally ill patients, don't really know what to do. So that definitely ties in also. And then education. So there's a lot of literature showing that U.S. education doesn't necessarily have enough didactic or clinical in psychiatric care, because about 50% of U.S. citizens will experience a mental illness at some time in their life. So not necessarily enough in undergrad. And then there's not a lot of ongoing education. And so that was what this project ended up focusing on, was ongoing education and psychiatric principles for acute care nurses. So if you take a look at the objectives, we evaluated learning needs of psychiatric nurses, what they needed to know about, or of acute care nurses, what they needed to know about psychiatric nursing. And then based on that, I was going to develop a module on one identified learning needs, which you guys can take a look if you want. You can pass it around. And based on the other identified needs, provide recommendations for further learning that could happen elsewhere in the hospital. And so my program really does a lot in implementation science. And so we have a lot of great research over here that says this is how we do it, and then there's practice over here, and there's like a 10 or 20 year gap in getting from here to here. And so I use the implementation model, the knowledge to action framework, and there are the steps that I used, which are in this, if you guys want to take a look, or they're up here, to try to get this information into practice. And then methods. So for the actual assessing learning needs, I use the Behavioral Healthcare Competency Survey. And it is a tool that was designed specifically for acute care nurses, assessing how much information they had about psychiatric care. It is actually validated for inpatient settings, and it assesses 4 areas of competency: psychiatric assessment, behavioral interventions, psychopharmacology, and resource adequacy. And then the other thing that I did was interviewing, actually, and that's part of the implementation model, is to interview, to assess barriers and facilitators to the project. And so I did in-person surveying, which actually had an 86% return rate, because I used cookies and I showed up on the unit. Very low barrier. And so, but there's some very good information, and then other methods we'll talk about. So, survey results. So we found that there were 5 areas that nurses said they would like more training in. Distinguishing between delirium and dementia, which I believe a resident somewhere is covering. And interaction strategies for patients with mental health. And so that more specifically asked behavioral, communication strategies, that sort of thing. Strategies for managing conflicts, and interventions specifically for patients who are hallucinating, and then psychopharmacology. These were all areas that were identified by the nurses as places they could use more education. And then the interview results, when I was asking about barriers and resources, I'll actually cover in recommendations. And then the learning module, so we got together, analyzed the results, and then it was decided that I would do a psychopharmacology module, and that will actually be implemented into the LMS system. And partly that was because it's hard, you can't teach communication on a computer. So, and other parts of the hospital are covering other areas of learning that were identified. And so the learning module covers target symptoms, monitoring parameters, common side effects, serious side effects, and pharmacological management of aggression and agitation. And so the recommendations that came out of a synthesis of the survey and the interview data were, number one, that nurses are open to more education, that they are identifying in this area that they could use education. So my recommendation there is to incorporate identified learning needs. Behavioral care plans came up. They were identified both by nursing staff and by management as something that's not really adequately utilized. Nurses talked about different shifts, doing it differently, lack of consistency between providers, management, having them revise, but not everybody being on board, the patient not having buy-in. So my recommendation would be to evaluate how they're being developed, how they're being implemented, and how they're being revised. Another area of recommendation was resources. So data from the survey said that nurses were saying that they could use more resources. And in interviewing, they talked about, the nurses had really, really good suggestions of what would be helpful to them. They said greater contact with psych consults. They had a suggestion of maybe they could have nurses that had extra education in psychiatric principles that could be a resource for other nurses. They talked about, can we just get a psych person here all the time? And so my recommendation in that is to assess what supports are available and what is a deficit. And then there are a lot of different models of how people provide psychiatric support to medical units. This is not a problem that's just here. It happens everywhere. And then systems. So during interviewing, multiple staff identified a breakdown between the emergency department, psychiatric staff, and medical floor staff. And they were saying that this breakdown in communication can lead to poor identification of ITA'd patients, involuntarily detained patients, which can lead to them not being evaluated in time, being released on a technicality, or medications not being started, like home medications not being started fast enough. And so the recommendation would be to take a look, see where communication is breaking down. And then the last recommendation is to take a look at the environment of the unit. And so we talked about that in the factors, doing a review of literature, looking at best ways to modify a medical unit for psychiatric patients without turning it into a psychiatric unit. And maybe that could be a future capstone. Any questions?
So So just for the group, because this is such a rich area and it has been an area for the organization, a little bit of angst, I think I can say with safely. There has been a lot of development since you did this, and it was your information was very, very helpful. There is a small working group that's including the emergency department and the acute care staff and the hospitalists and the CNO that are working on enhancing and improving our behavioral care plans and the care plans for IV drug abusers, and they're pulling in education now because they're close to finalizing that with how we're going to roll that out to the staff. There was a dedicated psych NP position. That position has been vacant for a while, so we're really looking at whether that needs to be a nurse practitioner, whether that needs to be a CNS, how can that be a support to the floors, as the inpatient acute care floors, as well as to the psychiatric service. We also have commitment from administration and from nursing services to open a new unit down here, a new old unit, an old new unit, a new refurbished unit down here in this wing, which will be a medical unit with psychiatric and IV drug abuse population, so that we can target education and curriculum specifically to that group of nurses. And it may have a slightly different nursing model and nursing matrix than some of the acute care floors. So that is in process. The final thing I wanted to say was for the new nurses that are being onboarded here, both the RN residents and the crossover nurses, the nurses that are coming in who have come from outside of the acute care services. David Gurdon, who's our Director of Behavioral Health Services, is doing an hour-long class on ITAs and caring for these patients, and what is our psych liaison service, what is the support to them, when can they call, and what resources are immediately available to them. So those are just some of the pieces that we put into effect. And our Elizabeth Evans, who's building our learning management systems, already has her PowerPoint and has turned it into the rough draft of a learning management system. We'd like to pick the brains of several people in this group to be able to preview that before we roll it out, and to help us decide what population it should be assigned to. So lots of movement behind the scenes on that. So yeah. Great.
Awesome.
Now, having given that little promo, let's go back to what are the questions you have regarding her project and the theoretical undergirding of the project, and what are her recommendations. I think you heard in the intro she's got a pretty broad experience level, both as a social worker and as a nurse in this area. So you've got things to ask. We got the expert.
Yeah.
Leanne, anything from your?
Not that's coming to my mind right now.
Okay.
I had one question that came
Please do.
up while that I think nurses a lot are asking themselves is like, why are these patients on my unit?
Mm-hmm.
And I looked into it, and there's like a psychiatric bed availability problem, but there's also like this divide in nursing that this is your body and this is your mind, and they have nothing to do with each other, and it's so not true. Patients who have a mental illness are 5 times more likely to have a serious physical illness, diabetes, heart disease. They are more likely to have more complications, longer length of stay. Like, they're coming into the hospital sicker, and they're gonna be on medical units. And so I think a shift from this is a psych patient, this doesn't belong here, to these are patients like everyone else that we see, and we need services in place to help us support them and support the staff that do have an extra burden. Anybody else have actual questions?
I was gonna say, I just have a comment. I think it's important too for staff to know how to take care of these patients, because it's not fair to the patient that's being here either, like you were saying. Yeah, they have a mental illness, but they have all this other stuff going on too. And so, again, it's the divide, and we have to have staff that know how to take care of them. But it has to be, what do I want to say? The staff have to feel safe though, too.
Yeah.
And I think, for a lot of the psych patients, the environment, like you were saying, can have a huge effect on that patient too. to have them calm, you don't wanna have a lot of stimuli, and those medical units do have, well, any
Where do
nursing
we
unit.
put them? We put them across from the nurse's desk, which
Right.
is the busiest
Well, the
place in the
phone's
hospital.
ringing, the
Yeah.
IV pumps are
Yeah.
going off, and there's just so much stimuli, which I actually think the environment probably causes the escalation.
Right.
Yeah, yeah,
So I
Absolutely.
think this is really good,
absolutely. Thank you.
and very much needed.
Thank you.
As part of your learning assessment needs, did you identify anything around like an understanding of the legalities of the ITA and
No. So the most of the survey is pretty specific. It's like a Likert scale of like how comfortable do you feel, and then the stuff about ITAs, like a lot of information came out in interviewing. It was like a wealth of information. It didn't really answer the question that I was asking, but it was very valuable, I think. And so I was mostly just listening and not assessing that.
It's like skills.
It was a lot, you know. People want to talk about it. It's stressful. It's hard. So.
I'm wondering, around the communication aspect of it, did you hear any feedback from the staff regarding debriefing around situations of escalation with a patient and how we're responding in that aspect?
We didn't talk about it. So they did say, and if you have time to read the executive summary, they did say really nice things about how that unit is dealing with co-grades. They said I think it was a assistant nurse manager, said that they've really done a lot around doing co-grade drills, doing debriefing, and that it had really, they felt very supported. They felt like their staff had really gotten it together. That's the only feedback I got from them. Any other questions? All right.
Good job.
Thank you guys.